And this is the Standing Committee of the Western Cape Provincial Parliament on Health. So it is my pleasure to thank all members and officials of the department, to wish you welcome to our Standing Committee meeting this morning, members in chambers as well as members online. I would now afford there's only one member in committee this morning. I just need to indicate for the record as well that the notice that went out for this meeting was that we were going to have an in-person engagement this morning. The only apology received was that of member Lorraine Botha, and member Gillian Bosman is standing in for her and he is online. Then I will now afford the member in committee in person to kindly introduce himself, please.
Good morning, Chairperson and the department. I am Regan Allen, a member of the Standing Committee, but I want to say, Chair, based on your comments made, thank you for addressing that first time in terms of the absence of members of this committee.
Thank you very much, Member Allen. I will now afford the departmental officials present to kindly introduce themselves.
Thank you, Chair and members. I'm Dr. Karim from the department side, and I'm the Chief of Operations. Thank you very much.
Good morning, Chair. I'm David Benza, the CEO of Khayelitsha Hospital.
Welcome to both officials. Member online.
Good morning, Chairperson. Gillian Bosman. I'm standing in for Member Lorraine Botha. Sorry I couldn't join you physically. I just had to come and say goodbye to my old constituency.
Thank you very much for your attendance, Member Bosman. And again, now I am looking at the procedural officer, that we do take up this matter with the Speaker's office as well as with the relevant whip of parties that are not present here today. I think sufficient notice were provided and we are most serious in terms of our oversight role as a committee. So it is really unacceptable that members do not even tender an apology for a scheduled standing committee meeting. Having said that, this morning we have the Department of Health in the Western Cape, the department, or rather the management of the Khayelitsha District Hospital. And that is one of the resolutions that we as a standing committee took for the management of the Khayelitsha District Hospital to come and brief this committee based on various media reports. I see Member Winvogel. You can please introduce yourself for the record, member.
Thank you, Chair. My sincere apologies. My name is Rachel van Vogel, member of this standing committee. Thank you.
Thank you, member, and welcome. I will now, without further ado, let me just also indicate to the procedural officer that Member Turgo left our WhatsApp group, which the standing committee has, and I have engaged with Member Makamba Bocha, who then indicated that she will stand in for him this morning. So I just needed to stress that for the record as well. I will now, without further ado, ask the Khayelitsha District Hospital, the department, to please present to the committee. Thank you.
Thank you, Honourable Chair and members of the committee. I'm going to ask David Binza to do the presentation. I mean, no Peru was submitted, and maybe we can just run through the presentation. David, over to you.
Thank you very much, Dr. Karim, and the legislature. The presentation was shared with Mrs. Jamte yesterday. Khayelitsha Hospital. I'm just trying to open my. Khayelitsha Hospital was opened in 2012, and at the time, as a district hospital, it was run by 3 family physicians, as well as 1 specialist physician in emergency center, as well as 1 obstetrician and 1 pediatrician. And since then, the community of Khayelitsha has grown exponentially and experiencing a lot of surges, especially in our trauma unit, the weekend surges, as well as other seasonal surges, like in summer, we'll experience diarrhea surges, and in winter, pneumonia surges. And since then, Khayelitsha has had to evolve and move on with the times. And Khayelitsha now has 14 specialists, 2 specialists on each service. Of the 8, anesthetics, emergency center, obstetrician and gynae, orthopedics, surgery, internal medicine, as well as the only one that has only 1 specialist currently is the psychiatry. And Khayelitsha currently accepts referrals from all over Khayelitsha and surrounding areas, such as Mfuleni. And Khayelitsha is the same size as other district hospitals. But as I said earlier on, it has morphed off from just an ordinary district hospital, offering more services that should have been offered at regional hospital level. So hospitals of our similar size are Kalbrema, amongst others, Helderberg, Yester River, etc. And our general patients, in terms of the geographic service area, are referred to Tygerberg Tertiary Hospital. And our psych patients, they go to Lendagia. And Khayelitsha is dealing with the quadruple burden of disease. By that I mean a lot of violence and trauma injury cases, a lot of communicable diseases such as TB, HIV. There's a growing trend in terms of the non-communicable diseases as well, such as hypertension, diabetes, and other diseases of lifestyle. Because of the socio-economic conditions of Khayelitsha, there's a lot of diseases also that are affecting pregnant women as well as children. And there's now a strong growing burden of mental health conditions associated with most of them substance abuse. And this has been worsened by COVID-19. So this is often called the six colliding epidemics: violence and trauma, communicable diseases, non-communicable diseases, diseases affecting pregnant women and children, mental health, as well as COVID-19. We're experiencing a lot of service pressures, especially in our emergency trauma or emergency services, EC, especially when it's weekends, month end, public holidays, and when there's a soccer derby, when Kaizer Chiefs and Pirates are playing. We know we must beef up our services because people are going to indulge and overdrink themselves, end up fighting, hurting themselves, and presenting in our trauma unit. Mental health pressures, there's a lot of that associated with the socio-economic circumstances of Khayelitsha, such as unemployment, as well as substance abuse, amongst others, perinatal pressures, as well as theatre backlogs. And Khayelitsha is experiencing a lot of constraints because this is the only hospital in Khayelitsha, and the demand often exceeds the supply. The demand often exceeds the supply. Bed capacity of 340 beds only, and this is often exceeded, and we often find ourselves operating at 130% and more sometimes. That means we often have to deal with patients at about 446 patients or beds than the expected official beds of 340 because of the increased demand. And the two areas that are often that often exceed, their expectations are emergency services or the emergency center, as well as the psychiatry services. And despite these, Khayelitsha's mortality rate is often comparable to other facilities of a similar size, such as I referred to earlier on, Kalbrema, Yester River, Helderberg, Mitchell's Plain, etc., with our mortality rate ranging between 2 and 4%. The 4 which we have experienced, especially as a result of COVID-19. There are steps that have been taken to improve service level at Khayelitsha. The one is to strengthen, and we are busy doing that, strengthening the district health system. That is our relationship with the primary healthcare facilities, as well as community-based services, working towards what we call COPC, community-oriented primary health care. And we are also working with improving our relationship with the tertiary institutions, as well as other non-governmental organizations. And we expanded our bed capacity in 2017 as one thing that has been done at strategic level, and the commissioning of the CT scan with a view to improving the flow of patients, the seamless flow of patients from assessment, diagnosis, treatment, transfer or discharge of our patients. We opened up the blood bank also in 2019. Maybe what I'm also forgetting to mention in terms of CT scan is that we're providing this not only to Khayelitsha patients, but also to Khayelitsha Eastern patients. So Helderberg patients, Eastern River patients, they often have to be referred to us for CT scan. We commissioned our blood bank in 2019. And in 2021, as a result of COVID, we also extended our psychiatric beds by operating 2 extra wards in Lendachie, Ward 91 and Ward 103. And at night time, on night shift, there are matrons that are running the service. We do have an option of extending our staffing in order to cope with the workload by getting people to work overtime or employing services of agency. And then there's a planned extension of the hospital, especially when it comes to psychiatry. There's a 30-bedded ward extension of the psychiatry services that is planned for 2023. And we're in consultation with the Public Works Department and working towards that. That was the essence of my presentation. Thank you.
Thank you very much, Mr. Biza. Members, is there any further comment from you, sir?
No, I think perhaps Chair, just to add to that, I mean, there's obviously a whole range of services that have an impact on Khayelitsha Hospital. Mr. Binza, and I think 2 of the areas that Mr. Binza mentioned, one is obviously mental health pressures. I mean, that's just right across the province. In fact, mental health service pressures have really, particularly since COVID. And we were at the Budget Policy Committee about a month ago. We are presented to the Policy Committee, and obviously members of Cabinet would have heard it before as well, in terms of mental health pressures and what the department aims to do around mental health pressures. So hopefully Khayelitsha will obviously also benefit from the expansion in the mental health service to try and deal with it, and particularly worse since COVID, obviously has since COVID. So there are other services around the Khayelitsha that will benefit Khayelitsha as well as benefit other areas of the Department of Health. And members of the legislature would have known and heard about the surgical backlogs, etc., etc. So there's some additional funding that we've allocated to try and improve a range of services such as mental health, such as surgical backlogs, etc. And obviously Khayelitsha Hospital will also stand to benefit from those expanded services. But thanks, Honourable Chair. I mean, I'm happy to take any questions on clarity or on Khayelitsha Hospital and or any other matters.
Sure, thank you very much. Any questions from your side, members? I see Member Allen, Member Windvogel. I see Member Bosman in that order.
Thank you so much, Chairperson. Whenever I think of Khayelitsha, I'm reminded that a couple of years ago, my mom was moved from Mitchell's Plain to Khayelitsha because Mitchell's Plain had staff shortages. That was many years ago. So there's inside of me, there's a sense of Khayelitsha helped. And I traveled to Khayelitsha during a very difficult time. So that's always in my head. But what I want to say is that, are you able, and I know you touched on it now, but are you able to elaborate on the engagements with the department? I know there's been media articles about 100 million rand that you require in terms of staff shortages and of resources. What type of interaction has the hospital had with the department in this regard? And are you privy to any information that was sent back to you in terms of the department engaging Treasury in this regard? That's my one question. And has there been any interaction with the local clinics as well, where patients are rocking up at the Khayelitsha Hospital and where they ideally should have or could have been seen at the clinic, so that working together with different spheres of government, how has that interaction gone? Are you able to share information in that regard to what steps have been put in place regarding, because one of the simple things is the management of crowds and of patients coming in, communication, chairperson, which goes an extremely long way when patients at least know this is the waiting time, there is movement, etc. Are you able to share a bit in around that in context, please?
Thank you very much, Member Allen. Member Van Vogel.
Thank you so much, Chairperson. Chairperson, I'm not sure if the Minister and the HOD is part of the meeting.
No, our invitation was specifically to the management of the Khayelitsha
Okay,
District
because
Hospital.
I see on the request, my request was the department. Also, I sent in also a request. Briefing by the department. So if you are saying the department, then I expect the department to be here. So I'm really concerned about that we only see it's like in Khayelitsha, not the issue for if we are going to treat this issue as if it is just an issue. And then I don't want to attach the color here.
Sorry, Member Van Vogel. Just before you proceed, I've been informed by the procedural officer that the invitation has been extended to the members, rather to the minister's office, and the minister and the HOD are in cabinet, but in cabinet today. So they have tendered an apology.
Thanks, Chair. Nevertheless, as I'm saying, that was my understanding, but thanks for that information. But it's really a concern for me, especially if it comes to the Khayelitsha Hospital. Their presence is so much needed now in this sitting, in this meeting. But nevertheless, Chairperson, I want to first thank the CEO and our COO.
Chief of Operations and Mr. Binzer, obviously the CEO of Khayelitsha.
Okay, for availing themselves for this important meeting. I see it very important. As well for the available information he has said, or they have said with us, since the visit we had at the hospital. It is clear to us that he and the hospital board are working hard to get things done, but they are not given the necessary support by the government or provincial government. That's my observation. Chairperson, from the presentation, I want to get clarity on a couple of issues raised. On slide, I see there's no numbers, but I give them numbers, slide 3 and 5, where the CEO shared that the hospital was opened 10 years ago and is now serving a large community with a high burden of diseases. I therefore wish to understand how has this rapid population increase in the area affected the functioning of the hospital, and whether the management and board have requested any assistance from the department with regards to the need for expansion of the hospital, and if so, when was this and what was the response? Then secondly, Chair, I also want to ask the CEO to elaborate. He raised on slide 3 that the hospital also serves as a regional hospital. What are the service offered at the regional hospital that are offered at KDH. Aren't these causing extra burden at the hospital, and whether there are additional resources that are allocated for these services? Then thirdly, Chair, on slide 6, there is a mention of bed capacity. That is officially run at 300, if I'm not mistaken, 340 beds, but is often exceeded, especially at time of the surge. How often is it exceeded and by what number? And how much additional funding is needed? I think member Ellen, member Ellen, our new MEC, mention I'm just supporting that question. I just want to know in terms of that funding, how much is needed to address. You mentioned some numbers there, and the challenge at the hospital, and what are the reasons for not giving the hospital. That's also to the department now, né? And why is that money not given to the hospital? And was it raised with the department? Chair, I think I will park there, and I hope I will get a second turn. Thank you, Chairperson.
I'm sure there will be room for follow-up questions. Member Van Vogel, Member Bosman.
Thank you very much, Chair. Chair, my questions, one is directed at the department as well as the CEO, and that is what type of community interventions are being done to educate members of the community on the role of the Khayelitsha Hospital, and also what type of awareness programs are done in the community to taper off the abuse of alcohol and drugs. And then my second question is directed to the CEO, and it comes out of a question by Member Van Vogel. Member Van Vogel stated that the hospital does not get any support from the Western Cape Department of Health. And I'd like to ask the CEO, are you getting support from the Department of Health? And is that support adequate? Thank you, Chairperson.
Thank you very much, Member Bosman. I was covered in terms of Member Allen's question, in terms of the budget as well as the engagement. With Treasury accordingly. And then on what Member Bosman has touched on. If you can please just put into context the situation when we say about service pressures. Is it the case that clinics, for instance, in the surrounds do not deliver the necessary service, and that necessitates clients to come to the district hospital? I've also read that sometimes patients come to the hospital and they're supposed to go to the clinic. How does that community communication, how does that communication go out to the various communities to make sure that the district hospital delivering the service that they are supposed to? If you can perhaps just put that into context. Then that, I also see for the record, Member Makamba Bocha. Welcome also to the meeting. I see your hand.
Greetings, Chairperson, and thank you very much for welcoming me in the meeting, and good morning to everyone, including the CEO of Khayelitsha. Chair, I'm not sure if you can allow me time to indulge on the discussion, even though I missed out on the presentation, but fortunately, I've got a background of what Khayelitsha Hospital is all about. Can you allow me time to ask a question?
Yes, please, member, proceed.
Okay, thank you very much, Chairperson. I just want to understand from the department, from the management of the Khayelitsha Hospital, in terms of your service level agreements, I think the Chairperson has touched on that. Seeing the circumstances that you guys are operating under, can you in this meeting tell us that you are achieving those service levels agreement? And if not, what are the action plans since the hospital has been in place? Because we've been getting complaints on daily basis about the service of Khayelitsha that is not well received by the community members. So what I want to know is, what is there any action plan that has been put in place to deliver a service or to better the services that they are currently delivering to the community? So I want to know, besides the issue of I hear there's an issue of the support from the department that it's not sufficient. So can the management tell us in this meeting, what are the action plans? What's happening in that hospital in terms of the way forward about what is currently happening? Thank you.
Thank you, Member Makamba Bocha. I will now give over to the COO and the CEO between the two of you. Thank you.
Thank you, Honourable Chair and members. I'm going to touch on as many of them as I can, and I'll ask Mr. Binza to pick up some of the others. So let me start with the funding and start with Member Allen's question and your question as well, Chair. So yes, we certainly have engagements with PT on a regular basis. As you know, we're busy with our budget allocation right now as we speak, and part of that engagement process that the department does on behalf of all the hospitals and services, obviously in the province, with PT has been going. I mean, we've been very good engagements, robust conversations. Certainly, I alerted Provincial Treasury to the needs of the department right across the board, in particular in some of the service pressure areas where we have. But as members would well know, when we have the other conversations about funding and annual reports and all of those, there are many needs in the Department of Health, and particularly exacerbated post-COVID. And it obviously is difficult from a department's perspective, because we do try to accommodate all the needs right across the department and then all our institutions that follow as a result. But remember, Alan, yes, we certainly have had very robust engagements with Provincial Treasury, and certainly put our needs as a department across the Provincial Treasury. But I'm sure members would have oversight or at least insight into allocations to other government departments as well that are also equally under pressure. So the pressure is really just generally significant, and it's been right across the board, across all our services. In terms of Member Allen's second question, and there was another question on interaction with communities and local clinics, and Member Chairperson, your question as well in terms of communication with members of the public about which service to actually attend to. We've certainly had many radio campaigns and interactions, particularly in Khayelitsha, and I mean, Mr. Binza can talk a little bit more to that. But with the director of services in Khayelitsha, and is now Mr. Kruger, whom this house would well know. Mr. Kruger used to work in the HIV, in the HIV directorate, is now in fact district director there. He has had he has a very active engagement with the membership, with the members of the Khayelitsha community forums, about just engaging the community in understanding what hospital services are provided and what clinic services are provided. But as we all well know, I mean, healthcare just generally in Khayelitsha and other areas are under significant pressure. So it's not that the clinics are not providing or not working very hard. They are, in fact, the occupancies range. We members who have visited the clinics would know what the occupancies look like and what the queues look like in the clinics. It's just that the need is just so huge in terms of healthcare right across the board, particularly in Khayelitsha, that we obviously cannot meet all the needs of people in terms of healthcare provision. And that's just a notwithstanding Khayelitsha that we find that same experience right across the board. I mean, that having been said, when we opened Khayelitsha Hospital at the time, we thought, for example, as Mr. Binza presented, that it would be the equivalent of a district hospital with 6 specialists, that would probably be sufficient in terms of the analysis that we had done prior to the opening of it. But very quickly realized that no, so there's a whole concept called unmet need. In other words, if you're not providing a service, people don't know about it, and therefore they don't come. Very quickly realized that that's obviously not adequate, and therefore had to, over a period of time, as Mr. Binza presented, move from 6 specialists to what we now have as 14 specialists. So we obviously had to more than double the number of specialists, and yet it's probably still not enough. in terms of what's required. So this concept of unmet need is a huge issue. And we find even when we opened all of our other new hospitals like Kailicha and the ones that are still in planning phases like the Tygerberg Regional, etc., we'll probably find a similar pattern that we've seen right across the world in terms of unmet need that's now being met, that wasn't there before. And I think at the end of the day, when one looks at the indicators in the Western Cape province, and by that I mean the kind of what we generally use in public health measures, measures like for example, the DALYs and like life expectancy at birth, etc. Those measures generally in the Western Cape are actually quite high and the highest of all the provinces. And it's an outcome of additional provision of services that's difficult to measure in Kailicha, but obviously on a global scale, one can say that like life expectancy increases, etc., and all those measures then improve. So in terms of the local, but back to the point about the communication with local clinics, yes, I mean, that certainly has happened. Mr. Binza and both Mr. Kruger are actively involved in the fora in Kailicha and engaging with communities. And we've been on radio and we've had many communication campaigns about trying to get people to understand when to come to a clinic for services and when to go to a hospital for services. But I mean, people are also, it's difficult circumstances because if the hospital happens to be nearer where you live, you'd go there, because you can also get the service there, but it does put pressure then on the hospital. The same happens, same pattern happens from regional to say central hospitals. About 44% of services in our central hospitals like Grootskei, Tygerberg and Red Cross are in fact services that could be provided at the equivalent of Kailicha hospitals, the regional and district hospitals. So it's a similar pattern. Remember, Windvogel asked a couple of questions in terms of population increase in Kailicha. It certainly has exploded over years, and that's obviously added to the burden and the significant service pressures that we have in Kailicha. In terms of requesting support from the Department of Health, and that has come up. Member Bosman, I think, also asked about it. Certainly, I mean, there's a lot of communication between Mr. Binza and the Department of Health in terms of from our perspective, what we can provide and what services are offered. But like back to our earlier conversation about budget and service pressures, obviously those are limited, and we do what we can in terms of the services the budget that we've got available, in terms of the services and requirements that Kailicha has. Mr. Binza can comment a little bit more about that. There's also a question about the services offered. I mean, I think that part of it are in the presentation, but I mean, obviously, because we didn't have time to go into all of it, I mean, there's a longer list of services that we can provide to the House and make that available through yourself, Chairperson. Bed capacity often is exceeded, particularly in, as you said, in emergency center and particularly mental health. So those surges that happen tend to, it tends to be perennial. Runs right throughout the year in terms of that surge capacity. And obviously because of that, we've been trying to make sure that we try and increase as much as we can the bed capacity, not only in Kailicha, but also the services that we provide in the surrounding communities to try and expand that. I think there were some questions. I can't remember Windvogel's questions now. I write them all down. Additional resources, bed capacity, support from the Department of Health. Yes, I think I've covered those. Member Bosman's questions were about community intervention. We've covered, and as well as awareness raising, and the delivery of clinic services in the surrounding areas in terms of what the provision is. And then there was a question about the service level agreements and an action plan. I mean, I think Mr. Binza can comment about that. But some of those additional services are on slide. Oh, I just lost it now. But I mean, he had made a comment about some additional services that have already been. Oh, there we go. Slide. Well, it's the last slide. So this is number 7. Therefore, remember here that this is number 7 slide. But so those are some of the additional services that have been offered in terms of going forward. But I think in terms of the future, through the chairperson, obviously from a department's perspective, there are pressures around mental health, and we've allocated just generally across the board 30 million rand for additional service support around mental health. Surgical services, we've allocated an additional 20 million rand for surgical services backlog. I mean, that's obviously been, as we said, exacerbated COVID, and there are other service pressures also. I'm just picking up on the key ones that affect Khayelitsha Hospital. That total comes to 114 million rand that the department's allocated or reprioritized, let me put it that way, from within our budget, reprioritized that with the support of Provincial Treasury. And some of the hard negotiations that we've had with our PT colleagues around additional funding. So it's a total of 114 million rand of additional services that we will inject into the system, and particularly deal with the service pressures like mental health, like the surgical services backlog. There are other areas like obstetrics, neonatology are also key to that. There's some additional ICT support that's required from the Department of Health, and also palliative care. We found during COVID, for example, that our palliative care service really needed an injection of funding. So these are people who are both at end of life care, but also who just require additional support because they might have a terminal illness and therefore require some additional support. So we're pumping some 12 million rand into additional palliative care services as well. That total comes to 114 rand additional services that we will inject into the system in the province, Chair. David, Mr. Binza, you want to add anything to that? Particularly about community engagements, I think it might be useful to hear from a local perspective. Your and James's, Mr. Kruger's involvement in the fora and what you've been doing.
Thank you very much, Dr. Karim. Around the issue of community engagements, we're moving on, as Honorable Van Vogel earlier mentioned, to engage with community stakeholders. The past weekend, on the 18th, we attended a stakeholder engagement organized by the Health Forum under the leadership of Mr. Ntibongo and Tamara Sem. So in attendance there were, amongst others, all the some civil organizations such as TAC, SAMCO, and other organizations. So we directly communicated, are in communication with the stakeholders, community stakeholders. And Mr. James Kruger, our Khayelitsha Eastern Substructure Director, we are also in partnership with Professor Vera Scott, who's working for City of Cape Town. We are engaging, and we're together also in attendance to that meeting and speaking directly to the community. Some community structures. And we do get support. There's a billboard in front of Khayelitsha that states that if people are sick, they must think of going to the clinics first. And the clinics are providing a good service, as Dr. Karim said. I had the privilege of running Khayelitsha Site B, Khayelitsha CHC, Community Health Center, before I was appointed as a CEO in Khayelitsha. And we had a head count then, before COVID, of over sometimes 50,000 people coming through our doors. So the PHC service is providing a good service to the community. And there is a room for improvement, though, in terms of strengthening the relationship with PHC and CBS, and those engagements are ongoing, so that we work towards what we call community-oriented primary care, as I said earlier on. But that is often met with challenges that relate to the social determinants of health, the high crime rate, such as recently when our Mfuleni colleagues were going to the pop-up site in order to go and help with the vaccination of people when they were robbed at gunpoint. So that kind of limits us, it kind of stands on the way of us wanting to deliver a service to the community. And it does require that intersectoral collaboration, our partnership with other government departments, such as police, the community stakeholders in general, so that we can win and be able to provide a service to the community. We do get the support from the province. The The MEC has been on, in Kailicha. She's the one who organized the putting up of that billboard, also helping and assisting us address the issues that are relating, especially to EMS being robbed also time and again, because we rely, a lot on EMS. But those challenges that are facing EMS are impacting negatively on our provision of services. They have to be escorted now by police. It reduces the turnaround time in terms of our request to EMS and them coming to actually deliver on that. The premier also of the province at some point also came to the facility and asked what we would like to get. And we have made a submission in terms of staff shortages via the office of the director, Mr. James Kruger, who's giving a good support. We are in the process of finalizing, getting the substructure to make its input before that submission is made to the chief director's office and then to the province for consideration. We'll need about 100 and 150 million to address our issues. And thank you very much, Honorable Bosman, for sharing that good story. It does go a long way to our staff who are working very hard and are working under a lot of pressure to deliver the service. It does motivate, it does help to build the morale of our staff. So whether that is enough or not enough in terms of the support that we're getting, I think it remains to be seen. But at this point, we're at a point where we've quantified how much we'll need, not only for clinical services, because clinical services do have a dependence on allied health services as well as other support services like porters, cleaners, clerks, etc. And our interaction with the local clinics in terms of our engagements, as well as EMS. We want to, those patients that should not be seen at the hospital, because we're 5 stones throw away from Michael Mapongwana and Kailicha CHC. We rely a lot on EMS having to move those patients from the hospital, but with a clear system in terms of triaging and classification of those patients, whether they will be green, classified as green and yellow, then they should be taken to PHC or to the CHC, community health center that is, or primary health care, and the vice versa in terms of the orange and the red patients that should be brought to our hospital, so that we see to the much needed patients. And then in that way, that should also reduce the long waiting time. And in terms of the long waiting time, we do have a system in place called HECTIS that registers a patient when a patient comes into the health system. When a patient is triaged, how has that patient been triaged? And it does give consideration also in terms of age or even disability, in terms of having to prioritize such patients. It has a way of highlighting them and get our attention. And when patients have waited for long, we can see it on that system. And that is not only a system that only informs the service providers, but also the consumers of our services, our end users, our patients, because there's a monitor also in front where they can see when they came and whether they've been registered or not, and how long have they been waiting. And we do have, on a yearly basis, we do what is called triage audit, when we look at the waiting times, and then in line with the findings, then we'll come up and develop quality improvement plans. And our emergency center, as I said earlier on, it is manned with about 3+ consultants who are looking into that. So we're working very hard with the board in terms of community engagements, and the board is new. It has just been properly elected towards the end of last year. So we're busy starting to get on with our work as a board. There's rapid population growth in Khayelitsha. There are now shacks where there used to be no shacks. This has been worsened by land grabs that took place during especially during COVID-19, the COVID-19 pandemic. A lot of them. There's now even next to the hospital a growing number of the same shacks even coming to steal some of our pavement to do their own pavements. So it does show that the population growth in Khayelitsha next to the military hospital like 2 mil, there's a lot of shacks there where there used to be no shacks. So the population has grown exponentially, and our engagements also in terms of the provision of services, it is growing even more. And there continues to be people also, or patients from the Eastern Cape coming to seek services at the hospital. So in terms of our services, we do provide specialist service which could have been provided at the regional hospital. That's why I talked to those services that we are providing, provided by specialists. In emergency services, internal medicine, surgery, orthopedics, obstetrician and gynecology, pediatrics, psychiatry, and anesthetists. Those services, a whole lot of them are supposed to be at a regional level. But over and above those clinical services, there's allied health services, physiotherapists, OT, dietitians, etc., psychologists that are also provided at the hospital. And laboratory services by NHLS, forensics, Tutuzela, blood services, as I mentioned on my slide, and the newly established service is the one of ophthalmology service. So there's now eye services as well that is provided in Khayelitsha Hospital. And the 80 beds that we've had in Lendachie, Ward 103 and Ward 91 in Lendachie, it has helped with the expansion of our beds from that 340, because it means there's an additional 80 beds just to add in our capacity. And that is why I was giving the figure of 446, which takes us to sometimes 130% of about 130% of what we're supposed to be doing, meaning we're doing much more with the little resources that we are having. Dr. Karim has just indicated in terms of the money, what the process, what process the department is following in order to see that we do get the money. I've already alluded to the question of support from the province, and then the clinics delivering their service. And in terms of the service level agreement, the plan of action, there are those things that I alluded to earlier in my presentation, in terms of the expansion of bed numbers in 2018, commissioning of the CT scan, opening of blood bank in order to speed the turnaround time in terms of blood results, helping with the diagnosis and treatment of patients, the commissioning of the Lendachie beds, etc. But at coalface level, we do have strategies that seek to address those service delivery issues. Like the issue of staffing, as I said, we have made that submission because we depend on, somehow we find ourselves dependent on agency work. And with agency comes also some other challenges in terms of serious adverse events and patient safety incidences. So we do want to work towards full-time employed employees because it's easier to deal with them. The issue of step-down facilities, this was one of the COVID-19 learnings, that when we operated Tusong Center as an expansion of our beds, which was within a walking distance from the hospital, our clinicians could happily walk to the center to address or to attend to patients. So the issue of step-down facilities or intermediate care facilities, we only have Baphumelele that is locally accessible, but we do have access in other step-down facilities such as Zandvlei and Mitchell's Plain, or Aquarius in Mitchell's Plain. And conversations are ongoing with Baphumelele to extend their number of beds and improve the accessibility, their admission criteria of these patients. We are engaging with EMS, Mr. Lionel Griffiths, in order to start stationing an ambulance, whether in Site B or at the hospital, so as to make it easy transporting the patients between the three facilities, especially Site B and Michael Mapongwan, so that the green and yellows are seen at PHC, primary healthcare level, that is, and then the orange and red cases can be seen at the hospital level. So those conversations are ongoing. Yes, I think I'll leave it at that for now.
Thank you very much for that response. I am posing just a question based on what you said, Mr. Biza, in terms of the staff structure. Can you please just help me understand what you're referring to? Are you referring to vacant positions currently at the Khayelitsha District Hospital, or are you making a reference to personnel to complement the current service pressures experienced? And if I heard it's Dr. Karim correctly, he made mention of an additional 114 million rand reprioritized for Khayelitsha District Hospital. So would that not complement your staff, if I can call it inefficiency, if the pressures were taken off those various pressures mentioned, where the 114 million will then be ultimately allocated? If you can just provide me clarity, please.
Yes.
Can I just clarify the 114 quickly? For the 114 reprioritized money for the whole province. Obviously, so just and obviously Khayelitsha will benefit from it because, for example, I'll take mental health, which is a big service pressure. Out of the 30 million of the 114 is for mental health, and of that specifically in the Khayelitsha district, for example, there's enough funds for an additional doctor to provide mental health support and etc. etc. So the plan rolls up eventually to 114 million rand. So that's an example. Surgical services, for example, there's a 20 million rand of the 114 for the province, and of the 20 million rand, 13 million will be prioritized for the metro. And obviously, we just had the meeting this morning about how to prioritize within the 13 million for the metro for surgical backlogs, what proportions can go to the different geographic areas. So obviously, Khayelitsha would then also benefit from those additional resources. But Mr. Binza can answer about the staff pressures as well.
Okay, thank you. In terms of staffing, our submission is specifically with the in principle posts. In other words, those are posts that are there, but they are not vacant and they are not funded. So they are vacant but not funded. They're in principle posts, and so it's not posts that are there that are vacant and funded, because then we can just follow with those ones a recruitment and selection process and have them filled. But when they are not funded, it prevents us from filling those. But over and above those, we've identified gaps in the system, besides the in-principle posts that are there but not funded. Where we feel there are gaps, we could do with the additional staffing. So that is in line with that. That's a process that we must now do to get the input of the substructure so that we can get into some agreement in terms of what we could get and what we cannot get. We do understand, as Dr. Karim said earlier, that it does depend, a whole lot of this does depend on the availability of funding. And other issues that could alleviate the pressure on Khayelitsha, the building of the Bella Regional Hospital. It could also assist with our workload, because then patients, for instance, from the surrounding areas, such as including Fuleni, they could then be redirected into that particular hospital. But that's a long-term process, rather. Yes.
Thank you very much, Mr. Biza, and I will recognize you shortly. Member Van Vogel, I see Member Makamba Bocha, then after Member Van Vogel. Just while we are now on the topic, in terms of staff vacancies, how many funded vacancies does currently exist at Khayelitsha District Hospital, and how many unfunded vacancies? That means the need that exists at the hospital.
Unfortunately, I don't
Do
have
not
that
have the
figure
information.
of
Not
the-
a
I don't know
problem.
that
We
figure
will
either.
draft in our resolution and request. Thank you.
Okay.
Member Van Vogel and then Member Makamba Bocha.
Thank you, Chair. Just to slash on what the chairperson has said, I'm actually partly covered by the chairperson, but I just want to, in terms of your agency staff and full-time staff members, if we can get numbers in terms of that. I'm not sure, do you have it with you? But otherwise you can send it to the committee at a later stage. Then I also want to know, the CEO mentioned funding that will be made available. So if we can get something on writing to say that's the amount for Khayelitsha and for what it's going to be for Khayelitsha. Then, Chairperson, on the issue of the bed capacity, my understanding was there at the moment you have 40 beds. So what I want to know of what I want to understand, how often is it exceeded and with how many? I'm not sure if am I clear? Come again? I want to know.
Please repeat.
At the moment you are sitting with 340 beds. That's my understanding. So now you mentioned something about your bed capacity that sometimes is exceeded. I want to know with how many patients, because a bed is equal to one patient. So I want to know how many, with how many, and how often. That's the two questions on the bed capacity. Then, Chairperson, on slide 3, the CEO shared that the hospital accepts referrals from Khayelitsha and Umfuleni. That's my understanding. When did the hospital start accepting referrals from Umfuleni, and what challenges did this decision bring to the hospital, and whether there were any additional budget allocation with it? Can we ask the department to give us a detailed explanation as to why people from Umfuleni are referred to KDH and not to Easter Rivier Hospital, and how has this affected service at the hospital? Then on slide 5, there is a reference to mental health pressure. I'm not getting it. Can we get an explanation of whether the hospital also serves as a psychiatric hospital, or is it an unfunded function? What is the number of unfunded functions that are offered at the hospital and the costs attached to that? Chair, then on slide 7, on improving service levels at KDH, the need to strengthen the community and primary healthcare facility services is mentioned. I want to know whether the CEO can give us his opinion on the decision by the department to close down a number of clinics around Khayelitsha, and how does he think this will affect the functioning of the hospital? Then, Chairperson, with regards to the employment of agency staff, I think I covered that part. But I want to know what are some of the lessons, because I know when we engage with some of the staff members in Khayelitsha, their morale is so low. They are overworked and their safety was a problem. In terms of safety, can you explain to me, because that was one issue that was raised, the safety of staff members. And then what lessons have you learned from COVID-19 and how can these improve services at the hospital? Then, Chair, my last one is on the issue on creation of one was a ideal hospital. So in that sense, what is the total additional funding needed? You sent in numbers, but if we can get that number, so that in order for the hospital, what number is that in order for the hospital to operate well? And what are the infrastructure needs at the hospital? What is the number of additional beds needed? What, with regards to the level of care or packages of care, what would you say is the level of care and whether the amount of funding received matches this level? Thank you, Chairperson.
Member Makamba Bocha, is that an old hand?
No, that's a new hand, Chairperson. Thank you very much. Chairperson, I'm just doing a follow-up on the responses that we got from both parties from the department, from the management. I see the action plan that they're both referring to is of short term, and it will never address the challenges of capacity, which seems to be the major issue in the Khayelitsha area. They've made mention of robust engagement with Treasury Department about the issue of funding. That speaks to redress the current challenges of Khayelitsha. So I want to know if we can have access to that, those engagement in terms of what is really needed. And we can see clearly that the hospital is not coping with the demands of the community and it's overloaded with the work. So every time they are responding, I'm hearing them talking about the short-term plans that they are in place, the issue of community engagement, informing communities about local clinics and all that, and other stakeholder engagements. I want to know if these stakeholder engagement, are they effective enough? Because if you look at the inflow of Khayelitsha, it never goes down. It's always up on a daily basis. So are these engagements really effective? Have they measured in terms of whether they are making sense or they have an impact in terms of making sure that the inflow of Khayelitsha, it's not high as it's happening, because it speaks directly to how people are receiving services there, because they're not getting services as they're supposed to be getting. So I also want to know, because the CEO also mentioned the issue of 150 million that they've, I'm not sure if they've made kind of an assessment in terms of how they want to redress what is happening. I want to know is part of these discussions, are they talking on expanding the hospital of Khayelitsha, since they've also mentioned the issue of population growth? So the 150 million that the CEO spoke about, Does it speak on the issue of expanding the hospital, or is it just the issue of injecting for additional services and support in the hospital? Because really, it's not really making any sense. Even the 114 million that is going to be shared in the province amongst the hospitals, it's not going to make any impact in terms of, because it's about injecting for additional services. It's not going to resolve the issue of Khayelitsha, because the Khayelitsha issue, it's about the capacity of the hospital. It's not the hospital, it's too small to service the community of Khayelitsha. And I also want to emphasize on the issue of this engagement. If they are engaging with these stakeholders and the clinics and all that, but people keep on coming to Khayelitsha, what is it that the hospital is doing to manage that? Thank you very much.
Thank you, Member Makamba Bocha. I do not see any further hands, either here or online. You may proceed with the response. Thank you.
Thank you, Honourable Chair and members. I'll touch on a few and then ask Mr. Binza then to obviously add to that. Just in terms of hospital capacity, I just went online quickly as we're speaking, literally right now, and the capacity this morning is 134%. So it's obviously 34% above the official bed capacity. But I'm looking at the patient profile as we speak here online. I mean, a number of those patients are in the EC, obviously, and so they obviously still have to be seen. At the moment, there's one person that must still be triaged, and there are 4 that are waiting for the doctor to be seen. So, I mean, that's this morning as we're speaking, literally hot off the press. And obviously, there are patients waiting for beds to be admitted, and there are patients waiting to be discharged out of the beds in hospital. But the current occupancy of this morning is 134%. So the way we calculate that occupancy, obviously sometimes a bit misleading also, but it does indicate a capacity, a hospital that obviously is above capacity at the moment as we speak, as members have also pointed out, and as Mr. Binza has also pointed out, there's often part of that surge, particularly in the EC and mental health. And I've got a list of obviously the names of people as well, because I mean, these are confidential information. So, you know, we can see, the doctors can see the system online, who must be triaged, who must be seen, who's waiting for a bed, who's waiting for x-rays, who must be, etc. And so what the hospital management team then does is they obviously look at this and they can direct the resources as required to try and make sure that people don't wait too long, or if there's a very urgent case that patient is seen first, then the red patients, then the orange, and then yellow and green. So there's a whole system that's live, and it's in all our EC system, and Mr. Binza referred to it. It's called the Hector system. And it's live, and we really rely a lot on the system to allow us to manage the pressure on the day, literally on the hour as we speak. There are a lot of questions that are very specific to Mr. Binza, but I just wanted to comment about the overall capacity, and for example, give an example of this morning's capacity. And Mr. Binza can comment on a number of the other questions. I think are more specific to Khayelitsha Hospital, I think. Yes, probably. Good.
Thanks, Dr. Karim. In terms of how many vacant posts, because I said earlier on, we've made the submission to the substructure, I'm able to give the number of posts that we feel we need in Khayelitsha, inclusive of the in principle posts and the gaps that we've identified for all 3 areas, that is clinical, allied health services, as well as support services. We'll need about 369 posts, and there is a breakdown of that has been given in that submission. That number may change, as I said. We'll engage still about this with the substructure, Khayelitsha Eastern substructure. So the director will call a meeting between ourselves, his HR, as well as his finance, in order to refine that document before its submission to the chief director's office. So the number is 369. And with the newly revised per capita numbers, we'll need about 150 million to do that. So that is in terms of the numbers vacant in principle, and the gaps identified by, especially in those areas where we can use agency. allied health services and clinical services. That is the doctors, the nurses, OT, dietitian, etc. Because in other support services, we're not using any agency. And by how much do we often exceed our numbers, and when and how often? We'll often go up to 446, as I said earlier on, instead of the 340 beds, official beds, that is. And what has helped us was that expansion of beds, as I said earlier on, which took place in 2019 by opening those 2 wards for the females and the males in Lentachie. So we'll go up by 100 and sometimes up to 106 more patients or more beds. This often happens, as I said, is sometimes just certain times of the month, like weekends, public holidays, as well as month end. And on other social activities, like when there's big soccer matches, the derby that I referred to earlier on, when we'll have to beef up our staff in order to cope with the expected high load. And Mfuleni patients, why were they diverted to Khayelitsha? That was a decision when the chief of operations then, Dr. Kluti, who is now head of health, organized a walkabout in all the hospitals, Khayelitsha, Yester River, and then Helderberg, looking particularly at the service pressures in around our EC, emergency center services. Fuleni, Yester River rather, is very small built. It used to be a private hospital, and the workload is just far too much on Yester River. As having been part of that walkabout, those patients are better taken care of in Khayelitsha than in Mfuleni, because with the increased workload there, for instance, in our EC, we could see patients that were lying on and seen on passages. In the design of Mfuleni, of Yester River, hospital, also it did not help with assisting those patients. Yes, it has made an addition in terms of the workload, in terms of Khayelitsha patients, and on counting this with the mental health patients, it made an addition of around 10 and 12% extra load, especially when it comes to psych patients in that area. And it would have helped if we had got additional resources, and it's not just human resource, but also in terms of the infrastructure. But as I said earlier in my presentation, there is a planned extension of the psych ward in Khayelitsha, which is going to take place in 2023. As of now, we are engaging with the public works, and we're going into they are busy setting up a meeting with the assistance of the CLO, the community liaison officer, and the professional support services, Ms. Razia Valley and Ms. Tonga. We're going to go on community engagement for employment opportunities and all that to the locals, so that that project is not halted when it must be built. So it will help to address the workload. But our current pressure, it is already more than the planned 30 beds. It actually would have helped if it was double what we are going to get in order to address the increased workload. But in terms of engagements with Lentachie, those engagements are ongoing under the directorship of Mrs. Carol Dean. We are engaging in terms of how to speed and strengthen the movement of these patients so that they do not stay more than the 72 hours that is warranted by the Mental Health Act, which says post 72 hours, these patients should move into psychiatric institution. Currently, the average length of stay of these patients is 22 days. That is 528 hours, as opposed to the 72 hours that is stipulated by the Act. So we are working with Lenda here to improve the movement of this seamless movement of these patients between district hospitals and the specialized hospital. It does add the difficulty in accessing these psychiatric beds. It does add pressure on the health services. As I said earlier on my presentation, the services that are often put under pressure, are emergency care services as well as the mental health care services. Yes, there is also pressure. There are also pressures in other services such as perinatal, as I said, or maternal and child health services as well. But this adds a lot of pressure on us. So why patients are not moved to Eastern River Hospital? They would better, in my view, they are better taken care of in Khayelitsha District Hospital than in Eastern River. It really was not nice to see the conditions then in Eastern River. But as I said earlier, it could help the rebuilding of the regional hospital in Bela. It will help to alleviate the pressure in both hospitals, Eastern River and KTH, because then the pressure will then be evenly shared, and then perhaps that decision also could be revisited. As a result of the extended average length of stay of these patients, it often ends up resulting in unfunded mandates, where we have to depend largely on agency personnel to render the service, because we're not geared to deal with the extended workload, but we do get allowance to use agency to provide the service. And in terms of the morale of the staff, yes, the morale of the staff is low, and we are doing everything possible to improve it by engaging on team building activities, amongst others, celebrating some calendar days such as Heritage, in order to bring in that unity to the team. But the safety, it is an issue, and it is an issue that is bigger than Khayelitsha Hospital or health institutions. It needs police to come in. Our staff continue to be robbed at the bus stop. They cancel sometimes even their shifts. As I said previously, our psychiatrist registrar was shared whilst on route to work, robbed at gunpoint as well. And the EC specialist who was supposed to assist in our EC had to cancel also his shift on the day. And as a result of the fearing for his life. So that's when this intersectoral collaboration, a partnership with the other government departments, but over and above, the need to form partnership with the committees, stakeholders also, so that we together reduce the safety risk, so to speak. And if the primary healthcare level is not functioning properly, it does have an effect, a negative effect on the district hospital, on how well it functions. So it does help if the primary healthcare facilities to remain open. But it depends on what is the workload, what is the head count, for instance, in those facilities. Is it generating a lot of head count? In other words, are those facilities seeing to a lot of patients, or could it benefit and help if those patients are seen to another facility? I think it's an exercise that needs to be done, the monitoring and evaluation of what is happening in those facilities before a decision to close them is taken, because it does have an influence. Instead of the patients going to primary healthcare facilities, they find them closed, they will come to us. But we do engage at various platforms, including radio stations, radios Bonele, and that, as Dr. Karim said earlier on. The lessons, one of the lessons learned from COVID-19 was the expansion of our beds to Song, which I said is in a walking distance, where our clinicians could go walk across the field to go and take care of those patients. It did help a lot. It did help a lot. As a result, we didn't have any patients having to get tired of sitting on the chairs, because they've sat more than the required 6 hours on the chairs, resulting in them being tired and then opting to sleep on the chairs or on the floor. The banning of alcohol, it also reduced the workload at the hospital a lot. For the first time since the opening of our doors in 2012, we could even sit with empty beds for the first time in Khayelitsha Hospital as a result of the banning of alcohol. And Hectis, we could draw up a report, as well as Dr. Karim also said, where you can look at the conditions of those patients that we saw in our EC. As of now, about 70% of the patients that we're seeing in our trauma unit with the unbanning of alcohol, it has again gained momentum. It's about 80% of the trauma-related cases that are often associated with alcohol use. So the partnership in terms of that intersectoral collaboration, the closing of ship-ins at the right time, it does help to reduce the burden on the health system. It does help to reduce the burden on the health system. So extending the beds, if we could get more step-down facilities, for instance, in Baphumelele, which is not far from Khayelitsha, or bring a step-down facility closer to the facility, to really would help. It could assist a lot, instead of these accesses that are far from Khayelitsha in Mitchell's Plain and Makasa, Zandvlei, as I said in my presentation. That could help to improve the services in Khayelitsha, because then we'll have expanded our beds. The patients who are not acutely sick, in other words, could be referred and seen at those step-down or intermediate care facilities, and reduce the risk of having to end up with patients lying on the floor or accumulating patients in our EC, because there's no seamless flow of the patients through the system. Because from being triaged, as Dr. Karim said earlier on, then a decision is taken as to whether those patients will have to access a bed internally or externally. And the nature of patients in Khayelitsha suffering from the quadruple burden of disease, or that tsunami or the colliding epidemics, it often warrants that we spend more time in terms of the average length of stay of these patients that is extended than as opposed to the 4 days, 5 days that we require, so that other people also can access the service. Sometimes they are not ready at the end of that five days, and then we end up spending a little bit of more time with them. It really would help if we then can extend the number of beds. So in terms of the infrastructure, as I said, the only provision currently is that Khayelitsha will get another 30-bedded ward to extend our psychiatric beds. That is but the only one that is going to take place currently. We could have done with a bigger EC, because the population is, in my view, grown exponentially, maybe 2-3 times more what was said at the time, or the conceptualization of Khayelitsha before 2012, before Khayelitsha opened its doors. Thank you.
Thank you very much, Mr. Biza. I do not see any further hands. What I hear from the CEO as well as the COO is that there's actually an array of factors that contributes to the pressures at the Khayelitsha District Hospital. And as the minister always says, that health is everybody's business. I'm very glad to hear that the establishment has got a functional board at current, and I do think that in future deliberations, that board and the various forums that you mentioned should play a greater role. What my thought is just that taking into consideration all those factors, you were making mention about the influx of from other provinces. You spoke about the expansion of the informal area, which was not previously there. You spoke about the criminal element, but as well as the social factors, and especially over weekends, that contribute to those various pressures as well. So one would want to see also an holistic approach to what the hospital that is serving that specific community currently experiencing, as to how the intergovernmental or interdepartmental relations can be strengthened, also to ensure that some of those pressures can be relieved from the Khayelitsha District Hospital. That is just a broad comment I wanted to make. So, Mr. Biza, you did make mention in terms of the vacant positions. We will then now also deal with our members. Is that, do I observe the mood correctly? There's no further questions?
Chairperson, sorry to interject. I just want to know if my question have been responded to, because I haven't heard anything talking about the expansion of the hospital, except for what the CEO has spoke about in terms of expanding the psychiatric ward with the bed. So I have not heard anybody talking about whether there are any talks in terms of expanding the hospital, seeing that the population of Khayelitsha has grown into numbers.
Thank you, Member. You've got the question from Member Makamba Bocha in terms of expansion, whether there's any plans. Member Van Vogel.
Chair, I will put some of my questions of it will be part of our resolutions, but what I want to comment or just bring it under the attention of the COO. I really try to understand the way of working if it comes to the department. With the COVID, you have a budget where you can fix things within 3-6 months. Why is it so difficult now? When we go back to reality, it's difficult to fix these things. You are sending money back to Treasury, but you are saying you don't have money. So it's really, it's not right that people sleep on floors. We understand there's a lot of dynamics that you need to consider, and it's playing a role. But can't we take this of the COVID-19 way of doing things? Can't we implement it also now? If you look at, I don't even want to go to the rural areas. Touwsrivier is also a huge problem. I know you know that, COO. And then you mentioned something about Easterrivier Hospital, also in a bad condition. And then you want to close clinics. And I really try to figure out, what are you doing? If people are complaining, there are a lot of and things are not happening, of service are not rendering, because health is as mentioned by the chairperson, is everyone's responsibility. But we as the government, we as the representatives need to make sure that we put things in place for the communities. But thanks for the hard work, CEO and your team. And I really hope, COO, that you guys will really look into this. It's unacceptable. It's unacceptable. Thank you, Chair.
Thank you very much, Member Van Vogel. Anything from your side, Member? Alan? Nothing? Member Bosman? You covered?
Chair, I just want to also say thank you to the CEO and the COO.
Thank you, Member. Member Bosman?
I'm covered, Chairperson.
Gone.
Thank you.
Thank you very much. Dr. Karim and or Mr. Visa?
As I said, with the assistance of the board, we've just started engaging, and I'm hoping that these engagements are helping. They are going to help, and we're going to continue, engaging communities so that they can be part and parcel of those engagements, which will result in them accessing, appropriate care. So people that should be seen to at primary healthcare level will be seen to at primary healthcare level, and our own engagement between the consultants from the hospital, as well as the clinics, like the family physicians. Those engagements will be ongoing. The clinical meetings will be effected so that we continuously engage each other, and then the arrangement, if we do get those inappropriate patients, then they are channeled appropriately without compromising their care. So it's about patients having to access appropriate care. And in terms of the expansion of the hospital, as I spoke about the service pressures earlier on, we could do with the extension of the emergency center service, but the only one on the cards currently is the one that relates to psychiatry. Perhaps if the regional hospital that I alluded to, Bella Regional Hospital, is also built, then it may reduce the need to expand the hospital, because there is a need in terms of services also around those around that particular area. So we do have experienced pressure also in terms of neonatal, perinatal services, maternal and child women's health services as well. We could do with more beds in that area, but perhaps what has been planned for in terms of the other hospitals, so that the pressure is shared much more evenly, it could assist if those hospitals, that hospital is built. And perhaps what the country is also working on in terms of the national health insurance, in order to allow universal health coverage. If we make more movement in terms of that, the public service, which is currently serving a population of about 84%, it could help also to reduce the load on the public service, public health services such as Khayelitsha. And as such, it may not even be necessary to then have to expand Khayelitsha. But if that is being delayed, of course, we would welcome expanding Khayelitsha. Even the current expansion that I'm talking about of the psychiatric service, it will help. It will definitely help and reduce the need for those patients to be handled the way that they are sometimes handled, which often end up violating human rights amongst others, COVID-19 protocols in terms of the social distancing and all that. Because of the increased load, sometimes we find ourselves having to flout that just to allow, so as to allow people to access the health service. In terms of the funding that Dr. Karim referred to earlier, it does help. It does help. You know, half bread is better than no bread. It does help because we have a fourth theatre that is very difficult to have it operational. There's shortage of ventilator machines to have to operationalize that fourth theatre, for instance. And we were told to get some of that funding that Dr. Karim referred to earlier on, and that will then allow us to operationalize the fourth theatre and help to address the theatre backlog that I referred to earlier on my presentation. So it does help a lot. Yeah. Thank you.
Thank you very much, Mr. Biza. On that note, thank you very much to you as well, Dr. Karim, for your time this morning by presenting to the Standing Committee as well as to addressing the various questions and comments made by members. We do appreciate, and we will now deal further in our committee in terms of resolutions and recommendations that will then be forwarded to the department accordingly. So thank you so much for your time and all the best with your work. You will now be excused. You are welcome to have some refreshments in the members' lounge, if your time allows. But thank you very much.
Thank you, Chair and members.
Members, our last item on the agenda is our committee program. Namonde, I don't see any dates attached to March.
Chairperson, if I may,
Oh, sorry.
resolution.
I'm getting so cold in here. I think that's why I'm rushing it. Let's start with the resolutions then, members. I'm sorry. Please proceed. Member Van Vogel, can I advise that we resolve to get the necessary information from the department as we have indicated earlier on? That will give us as a committee the opportunity to dissect and interrogate what is provided to us so that we can go fully informed, whether we do an oversight visit or whether we get the joint committee in chambers, then at least we know we have the information to our disposal. So can we first request the information from the department that we spoke to earlier on? I know members spoke to Mr. Biza wasn't specific in terms of exactly how many positions are funded and unfunded, as well as the 114 million that are allocated to the province additionally, reprioritized. How much of those money are directed towards Khayelitsha District Hospital and for what purpose? That allocation to KDH will address the service pressures there.
By saying, before my resolution, you are saying that we must first get all the information from the department and then we can embark on this other.
Yeah.
Okay. Then perhaps just another to add that the CEO also share with the committee the submission given to the department urgently.
You got that, Tamonde?
Okay, let me read what I noted down first.
Sure.
The first resolution that I jotted down is the detailed information on the services provided in the hospital. That or answer. Then there was a question that was asked: how many posts are currently in Khayelitsha, and how many posts are currently vacant and funded, and how many posts are vacant but not funded? I think he answered that, but we can still ask because he said it's 300 and let me
Yeah, but
quickly
he
check.
didn't give the
Yes,
detail
so we can do that.
in terms of where and which position.
Yes. Then total number of staff in Khayelitsha and total number of agency staff.
Yeah.
I think that was member.
Yes.
Detailed budget projection for Khayelitsha in the next financial year. Because next day in April, I don't know whether you remember. Yes, detailed budget projection for Khayelitsha in the next financial year. So you want the budget.
No,
projection.
we want the 114 million reprioritized.
Detailed information.
Yeah.
Okay, let me say detailed information.
Which of those monies are allocated for KDH? Yes, sure.
Detailed information.
Reprioritized funding for the province, which of those monies are allocated to KDH? And the amounts accordingly.
On the reprioritized funding.
Yes.
Of
14 million.
Of 14 or 14.
114. 114. Member Ellen? Yes. Okay, sure.
Chairperson, I can't hear the members from the chamber.
Member Allen? Apologies, member.
We were just saying that we are missing member Makamba Bocha here in the
Okay.
office, but a timeline to the request for information.
Okay.
And okay, so the other one was I think member Van Bachel wanted information or explanation as to why people from Amfuleni are referred to Khayelitsha instead of Easter referred.
That was addressed.
That was addressed, so I must scratch it out. What is the number of unfunded services in Khayelitsha and the cost attached
Yes.
to?
Yeah.
This? What is the total budget needed for Khayelitsha? So I did not get that. The total budget. That 150.
Yes, I think, but perhaps he can include it in his submission, because I also asked that he must submit or share with the committee the CEO. Ne?
What must he share?
He must share with the committee his submission to the department. There was that he submit. He's saying he submitted like of the need of the hospital and all that stuff.
And what that amounts to.
Yeah.
For the facility to run optimally.
He said it's 150.
Supposed to be.
Okay.
Look.
Okay, then there was information on how many beds are needed in Khayelitsha. Because currently there is 340, and they said that the capacity is over. Yes. So now you want to information as to how many beds?
I wanted to ask now if they submitted a type of a business plan. I'm not sure what it's called. That should be contained in there.
Mm. So I must request the submission of the CEO to the department. Okay. Okay, that was all that then is the oversight to Kailicha.
Yes, but we will speak to that after we've received the information. So we're not going to program that, but the timeline as mentioned, by when would do we want? Mhm. Mm. Mm. Yeah.
Is there any other?
Member Allen made mention of a timeline to the request for information. What would be a reasonable time?
That's the thing about members who are not in the house.
And my chairperson, I also have some recommendation.
I will be with you now, member Makamba Bocha. What would be a reasonable time?
I'll draft the minutes, Chair, then I will.
Give them 2 weeks?
Yes.
2 weeks. Sure. Thank you, member Makamba Bocha.
Chair, thank you very much. I think in addition to your request for the action plan, can we also get access to the discussions that are taking place between the hospital management and treasurer in terms of the expansion of the hospital, as the CEO mentioned in the presentation? Thank you.
We have minuted that accordingly, member Makamba Bocha.
Okay, noted.
Thank you very much, members. There's no other business on our agenda. So from, I really just want to get out of here.
Chair, may I suggest that in terms of the of the dates, if you as chairperson can communicate that with us
Okay,
via
sure.
email, because we have the draft.
Yeah. Okay. And we can just confirm then. All right. Members, that concludes our business of the day. Thank you very much for your indulgence. Thank you very much for your valuable contributions and your inputs to this meeting. Our meeting. So for members that are here, there are some refreshments in the members lounge. Thank you so much to all members. Thank you to our procedural officer, Ms. Jamke. Thank you, Ms. Mary Ann Burgess. Thank you to our ICT support. Our meeting are now adjourned. Thank you, members.
Thank you, Chairperson.